This is Frances Russell, and in this module, we will review tips for performing ultrasound-guided vascular access.
So to get into some of the nitty-gritties of the procedure, tip one, you always want your indicator to the left, and that's going to be true regardless of any procedure that you're performing. So here we're using our linear probe or our high-frequency probe. We have our indicator here on the left side of our transducer. This is going to correspond to the left side of the ultrasound screen. So the reason this is important is if you go left with the needle in the patient's neck, it'll go left on the ultrasound screen, and you don't have to be left wondering or trying to do the mental math of which way the needle is actually going. Tip number two, you want to scan the entire vessel. This is important to be able to assess the trajectory of the vessel, make sure it's not branching, make sure there's no pathology that you may not otherwise know about for the patient. So you want to scan the entire vessel up and down the neck. Next, you want to compress the vein. So veins are going to be thinner walled. They're going to be easily compressible with just slight compression. And they're not going to be pulsatile compared to the arteries. This is your carotid artery sitting just medial to your internal jugular vein. And you can see it's pulsatile. You can see the walls are thicker as well. So there are two different ways to do this procedure. You can either do short or long access, and we'll kind of talk about the pros and cons of each. So here we have our internal jugular vein sitting on top of the carotid, and this needle is coming down in short access. So we can only really see the tip of the needle. So short access is a nice approach because you're able to see the back wall. So I know the carotid is sitting here, so you can go in with your needle just lateral to the carotid. And you can see what's next to the vessel on each side. The disadvantage is you have to make sure this is actually the tip of the needle and not the shaft because it will appear the same on short axis view. For long axis view, you can see pretty much the trajectory that the needle is going in. You can see the shaft in the needle as well as the tip of the needle. So you know that the tip is actually in the vein and you haven't gone through the back wall. The issue with long axis is you can't really see what's next to or on each side of the vessel. So we'll talk a little more in depth about short access techniques. So with short access technique, you want to go in with your needle directly underneath the ultrasound probe. So on the screen, you line up the vein in the center of the ultrasound screen, and then you go in with your needle in the center of the ultrasound probe, and you find the tip of the needle right as you enter the patient's skin. This is an example of that. So you go in with the needle. Once you're underneath the skin, you have your ultrasound probe and you slide your ultrasound probe away as you're advancing your needle. This will allow you to follow the tip of the needle and not the shaft of the needle. So this is what it'll look like on the ultrasound screen. It'll really just be a dot that you're following down into the vessel. So tip number three, and the most important tip, is you need to follow the needle tip. If you're not following the tip of the needle and you're following the shaft of the needle, that's when you cause injury to the arteries, to the lungs. So you want to make sure that you're always following the tip. So this is an example of what we call a target sign. So here we have our vein, and here's the tip of the needle. So you can see the tip of the needle's in the very center of the vein. So when people start out doing this, they look for a flash of blood that comes back into the catheter if they've hit the vein. That's not good enough to be able to place an ultrasound guided IV. You really want to see the tip of the needle in the center of the vessel. Then you can do what we call a vanishing target sign. So here we have our target sign. You can see the needle is in the center of our vessel. And you want to fan away off the needle, and you notice that the tip of the needle disappears. That tells you that that's the tip and not the shaft. If you were at the shaft and you fanned away, you would actually see the needle continue through the bottom of the vein. So you want to use this technique to verify that you're actually looking at the tip of the needle and not the shaft of the needle. The next step, or tip 4, is walking the tip of the needle down the vessel. And this can either be done in short access technique or in long access technique. So here you can see the tip is in the center of my vessel. And essentially, I've lowered the angle that I have for my needle. So I'm almost parallel with the patient's skin. And then I'm advancing the needle. And as I advance the needle, I keep it within the lumen of the vessel. And I'm also fanning my probe away. So I'm doing the vanishing target sign where I don't see the needle anymore, and then I'm advancing the needle. This allows me to bury more of the needle and more of my catheter into the vessel. So then when I go to either thread the catheter off or thread a guide wire through, I'm ensured that it's going down the lumen of the vessel and it won't just go through the back wall of the vessel. So putting it all together, so you come in, you look for the needle right underneath the skin, and then as you're advancing the needle, you're following the tip by sliding your ultrasound probe away from you. And then you can see here the needle's right on top of the vein. And now I'm in the center of the vein here with my needle. That's my target sign. And I'm doing my vanishing target sign where I'm fanning away, the tip's disappearing, and I'm advancing the tip so more. The needle is buried in the vein before I either pass the guide wire or pass a catheter. You can then confirm placement by looking for your wire. So once I've passed my guide wire, I take a look with ultrasound. So here I'm looking in long access of the internal jugular vein. This is going to be up towards the patient's head. This will be towards the patient's feet in long access. And here you can see that the guide wire is in the middle of this person's internal jugular vein, and you can actually see carotid coming in and out of view below. Another way to confirm placement, and especially in a patient who I'm really worried about, maybe I need to get the medications on board sooner rather than later, I don't have a ton of time to wait for chest x-ray for confirmation of placement, you can actually use agitated saline and put that into the distal port on your new line, and you should be able to see bubbles within the right side of the heart within 1 to 2 seconds with proper placement. And that's what we're seeing in this ultrasound clip. And then you would still get a chest x-ray to verify proper location.